Okay, so just to remind you, I'm an audiologist and clinician, practitioner, and I'm talking about working with those patients who are very bothered by their tinnitus and seeing if we can help them in their pretty negative, kind of desperate state. So yesterday I had a lot of really good questions after my talk, so I'm going to peel off from what I was going to do and just give you a little example so you can kind of understand some of these techniques and how they're used with the patient. So I'm just doing this off the fly. So let me give you an example. So we had a gentleman who had a noise trauma or traumatic incident with one ear, okay? So what did he do? Well, he saw the ENT, which was very important, and was deemed medically safe. He was referred to our clinic. He went to our group education session, and he sat there and he thought, well, I really want to do sound therapy, and I really do want to do counseling. So when I was able to work with him, his answers on that 12-item questionnaire were all very much at the high end. So we know, okay, he's really struggling in lots of areas, right? So we did do our sound therapy evaluation. He found a couple things to be helpful, but didn't want to, purchase yet or go down that route. So we met for counseling. We had a really nice introduction session where I could really understand what he's going through. There was a lot of emotion, a lot of tears, and he really felt like his life went from, very happy and kind of focused to extremely dark, and he was scared and sad and felt like, kind of life wasn't, worth living at that point. So I asked him, what is your goal for coming to this clinic? And his goal was to get rid of this sound. So we talked about how that's a beautiful goal, and I really appreciate that. And if I could do that, I would do it in a second, but I can't. So what do we do with that goal? It took us a while. But he finally, on his own, said, if I could get some better sleep, I think I could manage this sound better, but I'm so sleep deprived, it's just driving me crazy. So then, what do? I sat there and I said, well, let's talk about what we know. We don't know enough about sleep, and I'm really glad we have someone presenting this afternoon on sleep. But what do we know about sleep? So we went to the sleep section and started to just talk about sleep hygiene, just the basics. And what did I find out? He works third shift. Well, that in and of itself is hard because you're functioning opposite of, typical jobs, and even if you don't have tinnitus, sometimes that causes sleep deprivation. So he worked third shift. He got off work, and this is all just because we're talking about sleep hygiene. He got off work at 3 in the morning, and he said, I can't get to sleep easily. When I do fall asleep, I barely get any sleep. I wake up, and then I can't get back to sleep, okay? So what I learned is he gets off work at 3, he gets home, and he's trying to be in bed by 4. So the first thing we talked about is adjusting expectations. If you worked a day job, you wouldn't get off work and expect yourself to be home and in bed by 5:30 or 6. Probably not. Most people don't. So what's wrong with not falling asleep right away? Okay, I never thought about that. What do you like to do? I like to relax, watch TV. Well, let's give yourself that option. So let's come up with a new goal. Let's say you want to be asleep by 5. Now let's look at your sleep environment, and that's in that sleep section. Do you have curtains that, keep the sun out? Do you have all electronics out of your bedroom? And, go through those slides. He thought about it. Well, some of it he did, some of it he didn't. So what happens when you fall asleep? I wake up at 8 o'clock, and it's always routinely at 8, and the first thing I notice is my sound and it's overwhelming, and I start thinking about the accident and what happened, and before I know it, I just can't deal with it, so I get up out of bed, and I do tons before noon. All these running these errands and this and that, and by 12 or 12:30, I'm exhausted. Okay, well, let's talk about adjusting the morning. If you go to bed at 5 and we want you to have 7 hours of sleep, we want you to sleep till noon. For the next week, let's take away all of your activities that you do between 8 and noon. Tell yourself you don't need to do any of those. And let's see if we can get you to sleep just a little bit longer than 8. So what do we do at 8 o'clock when he wakes up? Well, that's when you can implement muscle relaxation, imagery training. Now, he's already doing imagery training, isn't he? He's waking up and he's going mentally back to the accident. So you're going to teach him to tweak his imagery training and change that and incorporate in some exercises so that, that muscle relaxation, so maybe he can stay in bed a little bit longer. You're going to, according to our tinnitus activities treatment, you're going to add lots of sound. You're going to enrich his environment with sound, so maybe the contrast between his tinnitus, isn't as much. And then you can start talking about thoughts and emotions. And that's what I mentioned yesterday I saw in my Blue Cross Blue Shield magazine, using some cognitive behavioral techniques, okay? Now, at the same time, he found the neuromonics device to be extremely relaxing, so he wanted to pursue that, so we added that in, okay? So the plan was, I'm going to touch base with you in a week with telephone counseling and see how things are going. If they're going in the right direction, we'll go another week telephone counseling. If we're going in the right direction, then we're going to go with a visit back in the office. Because maybe we've addressed some of the sleep stuff, and we can start talking about some other things. So in that first week, what he reported back to me was he would come home from work, and he felt much more relief to not be in bed right away. And he was able to relax and do some other things. He was trying to be in bed by about 5, and he was using the neuromonics device to kind of help relax him, to get him to feel sleepy and to fall asleep. And he was waking up at 8, but he was using some of these techniques, and he was able to get himself to stay in bed and fall back asleep. Sometimes it was a grazing kind of sleep, and he could stretch his sleep out to 10:30. And he could not stay in bed after that. 10:30 he was up. So that's a little bit of progress, right? And I asked him how it felt, and his feedback to me was, I feel a little bit more refreshed, just a little bit. But that's okay, right? Because we're going in the right direction. So that's an example of how you maybe could use some of these techniques. And if you don't see progress, then maybe you need to refer, or you need to stop, or maybe, focus on something else. But that's just a quick example, okay? All right, so with that being said, that's kind of what we do in this portion of our clinic. And we don't solicit feedback from our patients, but we get it, which is okay. And I just want to show you some of the comments. Thank you so much for your time, advice, knowledge, understanding, your ability to articulate this, and your ability to give options. And I think coming on, the back end of the talk we just heard, that's probably what the ATA would like to be able to do on a routine basis, is refer to people who can do this. And hopefully it's most of you in this room. Okay, so what have we learned? We know that we need to make our clinic a safe place for a confused patient. We need to be able to provide answers. We need to kind of help point them in the right direction, kind of give them a refuge to be able to do this. A lot of times it gives patients strength just knowing that someone has their back, but it is very unique and it's hard to fit into ENT clinic and private practice clinic, so I understand that. So when you think about your responsibilities, you want to be able to listen and be patient and be sympathetic, be encouraging, be able to talk. If you're shy and you really don't want to do a lot of candid talking, then maybe this isn't an area you definitely might not want to be in. You have to have confidence in just your ability to help, never to fix it, because you can't fix it. You need to be able to guide and ultimately have the time. So I remembered yesterday that I met a couple years ago at a conference 2 women who are in private practice. And what they've done is they have set up 2 separate sites. So in one site is their standard clinic for patients who their primary concern is better hearing and better speech understanding, and a separate site for their tinnitus patients that provides some of these things. Now, in the end, your patient in the first site may end up with a similar product as your patient in the other site, but the process to get there is very different, and that's why you have to bundle in that time element, because your sessions are longer. If you're going to use any of these amazing features that we heard about this morning, you're going to want the time to explore them. You're going to want to be able to chat and communicate with your patient as you're making these adjustments. So it's a completely different type of direct service, okay? So you also really need to be willing to address additional support. I'm talking about the patients who are greatly bothered, okay? And sometimes you need to work in conjunction with a licensed psychologist or a psychiatrist, and I love those partnerships, and they go really well as long as your patient has the basic tinnitus base, the understanding, and the clinician you're working with does as well. And then I think it's a great partnering of the 2 professions. So now I'm just going to share with you some tools, some tips, some things that I have found helpful, and some roadblocks that I have seen purely from my own clinical experience, okay? I feel like you really need to understand the basic psychology of your patient before you get too far in. If I had spent all that time talking about sleep hygiene and never even knew that this gentleman worked 3rd shift, I'd be off in how we were adjusting things. So it has happened to me before. I was working with a gentleman, and man, I just felt like we couldn't get anywhere. He was very depressed, and I just couldn't help him, and I didn't know why. And then I realized one day in passing, in a comment that his wife made, well, he's been diagnosed with dysthymia, and he's had it his whole life. So I was working against something that was already there. So maybe my, expectation was wrong. And so I think you really need to know if you have a history of someone with some major depression or some anxiety issues, because that can really kind of dictate what you think, your end result is going to be. Okay? We have some slides that can help have that discussion. It's not easy for everybody to have, but it is a really important discussion. Okay. I like to set goals, as we said yesterday, goals for hearing better, goals for sound therapy, and goals for counseling. And some of the things that patients have come up with in the past is to not hate my tinnitus as much, to be able to return to a normal life. Hey, I just want to attend meetings again and be able to comprehend and walk out of there with some knowledge. I want to go to a movie again. When you set these goals, then you at least have, a place to start working from. And I think everything boils down to understanding that connection between your thoughts and your emotions. If we go back to the gentleman with the sleep issues, when he would wake up at 8 a.m., his thoughts were very quickly going in a direction that was creating some, emotions that were hindering him from feeling good. Okay, so if you can really stop and work with your patient on understanding that connection, like we talked about yesterday, identifying what those thoughts are, and then being able to either address them in some way or refocus yourself away from them, then I think you are doing them a great service. Okay? How do you do that? So you're sitting with a patient and their thoughts are, really negative and their emotions are really negative. Well, do you remember that picture I gave you yesterday of those cards that I saw on the wall in that elementary? Well, I use those with patients. I had been way before I saw them on the wall there. I just take out index cards, and after they have told me their list of how they feel, we put them on those cards. And their choice is to take that card on the front that says, I hate this sound, and flip it over and change that in some way. And they are visual cue cards, and I have people put them up, just like you saw them in the the hallway of that elementary. Put them on your mirror in the morning when you wake up. Put them in your car. Put them in your kitchen on the refrigerator, or even tape them to the cupboard, okay? And then we always throw in a wild card, and a wild card is a blank card. And that card is meant to say, what am I thinking about right at this moment? Instead of having these cues that tell me this is what I'm typically thinking, and then flip it over or have one next to it that shows you kind of maybe a different way to think about it, what am I thinking about? Oh, yeah, you know what? I am on that negative end. A wild card just lets you assess yourself. This is the best book in the whole wide world if you want to go into this area of treating a patient. It's as good as Rich's. Let me just say that real quick.
I agree with that.
But he would agree. This is really, really good. Read this before you see any tinnitus patient who is greatly bothered. There are great techniques in here. Thought stopping. How do I stop those negative thoughts? How do I distract myself? Okay, let's not try to work on that. Let's increase positive thoughts. How do we do that? Let's schedule more positive things into your routine. Let's look at, pleasant sounds. Some of the things, like Julie was talking about in her presentation earlier, the apps, they're all over the place, and the Resound app is wonderful. I love it. Gives you all kinds of power, and sounds to listen to. And then there's lots of people who talk about mindfulness. And for many, many years, we had a woman here present, and I brought her stuff right here. And she had in the past tried to create, and she may still have it, an online program for tinnitus patients who want to do some mindfulness training. But I think what you need to do in this session is help your patient feel a physical shift from to, hey, or even just, that positive, negative, neutral, even in little tiny ways that are totally unrelated to tinnitus. Take something in life that has nothing to do with it. I'm just throwing this out here right now, if your employer said, we're going to give you the next month paid, but we want you to take off. We want you to have a vacation. How do you think, what is a thought you would have? How do you think you would feel? Okay? And you can feel a shift. What if your employer came in and said, budget's really tight, we need you to work, but we're not going to pay you this month? You can feel, you can feel that. So after you've helped them feel that with unrelated tinnitus examples, which there are many in this book, Then start talking about them, about their exact experience with their own tinnitus. There's a gentleman named Stephen Nagler. Many of you may know him. He is an MD. He's been here before in the past. He's wonderful. He was a very successful MD and had his own private practice, and tinnitus came into his life, and it completely turned his life upside down, and he lost his practice because of it. It was that significant. So he wrote a letter, and it's an amazing letter to other tinnitus sufferers on how he felt and what has helped him the most. And it's basically focused on that thought flipping area. And I will have that on the website for you. I hand this out all the time, so you guys can use that as a resource. If you want to do a little cognitive behavioral stuff, you might be scared because maybe you feel you're not trained in it. In this book, again, there's a really neat section. Did any of you know that, yes, we have positive, negative, neutral thoughts, but if we go to our negative thoughts, there's 12 common styles. Well, who knew? Walk through these styles with your patient and highlight and figure out which ones are theirs. And then you can talk about how you can use that when they're having, one of those moments. Maybe you are jumping to a conclusion. And now that you know that that's the kind of person you are when you think negatively, how can we adjust that? So that's a really neat activity. Some people are afraid, again, to do the cognitive behavioral approach, but in the tinnitus counseling world, it's very, very simple. It's an ABCDE model, and you can write it out on a piece of paper, and it can be great homework. A is just the situation. It can be anything, but in our world, it's having tinnitus. B is the thought that you initially have, which for many patients, when it goes up to this conscious level and it's sitting there, it's, I can't live with this. C is identifying what emotions come up with that thought. D is, okay, how am I going to deal with it? Am I going to dispute it? Am I going to challenge it? Am I going to replace it? And once you decide what you're going to do, the E is what happens. And it's usually that shift to a more neutral feeling or even maybe a more positive feeling. It's not difficult to do. Don't be scared. Try it with non-tinnitus examples, and it can be kind of fun. Okay? So again, the two best books in the whole wide world, but this one is, trumping the other one if you want to do clinical work with a patient who's greatly bothered by tinnitus. Now you can take a completely different approach, and this is a book right here by Beverly Thorne, and she works with patients with chronic pain, and she says, let's not focus on the tinnitus, but let's focus on stress, because tinnitus causes stress, and let's manage the stress. And when you think about stress, stress does three things. There's a biological reaction, an emotional reaction, and a cognitive. So the CBT stuff is working on the thoughts, but maybe there's something we can work on with the emotions or the biological. So this would be an example. What if you have a patient, and I've had people like this who come in and say, prior to tinnitus, I have never, ever, ever had problems with anxiety, but I'm having all kinds of panic attacks all the time, and I am so anxious. What if we don't focus on the tinnitus, but we focus on that biological reaction? How do you de-stress? How do you manage anxiety? Well, I'm not an MD. I can't prescribe a prescription. I have asked, and I saw a psychologist raise their hand earlier. I'm going to probably reach out to you, but I asked every psychologist and every psychiatrist and every MD that's in the field, what's the best way to manage stress? And what I always hear is deep breathing. So I have some really good handouts to help with anxiety in an acute manner, maybe not long term, but someone who's in your office saying, I'm having so many attacks. So are we really addressing the tinnitus? No, we're addressing anxiety, which is, a side effect of what the tinnitus is doing for them, okay? If we think about stress and we don't think about the tinnitus, how are we assessing this stress? Is it a threat? Do they feel like there's danger? Because if so, it tends to lead to anxiety. Do they feel like some harm has been done and they feel like there's a great loss, which tends to lead to helplessness or depression? And can you get them somehow to adjust that to more of it's a challenge. It's a challenge, but it's okay, which is very different from loss, which is sad, and threat, which is scary. So again, focusing on the stress and not the tinnitus. These are some roadblocks I've seen. There might be more out there, but I have noticed that there are 3 big things. Not acknowledging the tinnitus, giving up ways of controlling it, and then, of course, I keep coming back to the controlling of the thoughts and emotions, okay? So sometimes you just need to ask someone how they feel about having tinnitus, because they may be going through life with this invisible disease and very held up, and they're seeing all these different clinicians, but no one's talking to them about it. And I think that when you are working with someone who's highly bothered, there has to be a grieving process. And it sometimes has to start in your office with you, because there is grief over not being able to just have silence. Or some people see it as a disability, grief over having a disability. So sometimes you need to help them just let go of this emotion. A lot of times it just happens naturally in the introduction section, and then you kind of have to watch it to make sure it's not an underlying theme. And if it continues to resurface, you really have to work on, are we going to refocus this? Are we going to adjust this? Or, what are we going to do about this grief? Do we need to see another professional? Okay. I think it's great. Like Rich made a comment the other day about opening up to the people around you to find out who else has tinnitus. But people who are greatly bothered fall in a special category. And sometimes they get really hurt when they ask other people who say, oh, yeah, I have it. It doesn't bother me at all. It's no big deal. So sometimes I will verbalize that, warn them. It's okay to talk about it, but be prepared. Because some people are going to think, what's wrong with you? You can't manage your tinnitus. What did we say? 90-some% of the people who have tinnitus aren't bothered by it. This is a unique subgroup. We don't know. What if we took the tinnitus out of one of those and one of these and we swapped them? Maybe the person in the 95 percentile area is going to go, whoa, this is tinnitus? This is awful. Because we really don't know yet, the subcategories of tinnitus. So, I'm just real cautious with that. In this book by Beverly Thorne, she has a great exercise for people who are really stuck in that grieving process. I won't go through it. You guys can read it and check it out for yourself, but it is a good exercise. All right, so some people physically feel like they can control their tinnitus. And maybe they can. If they lay down, they do this. If they stand up, they do this. And that's okay, but sometimes that dictates their day. And so, we really have to work hard at reminding them it's an auditory insult and taking it back to the auditory system and those slides and the discussion about it is a physiological thing. Tinnitus doesn't have a heart, and doesn't have a soul, and doesn't have a mind, and it's really not reading you and trying to muck up your day. And letting go. It is what it is. Here's your tinnitus. And here's your reaction, and it's going to do all kinds of things, and you can't control that, but you can control how you're letting it control you, and sometimes that discussion has to be had. Again, you guys can read through this on your own, but when you have someone stuck in that category, I always say, no internet searches. The only place you're allowed to go to is the ATA. Those are my exact words. And sometimes it's really hard for them to do that. Go and do whatever you want, acupuncture, chiropractic care. I don't care. But make sure your goal is for better well-being, not for tinnitus reduction. Patients will say, well, I'm not doing it for that, Shelley. I'm doing it because of my neck. And I know they're doing it because they think that there is yet something out there that they can do that will take it away. So again, a goal, do whatever you want for better well-being, but if you're doing it to make a change with the tinnitus, you're going to be very disappointed. That's the typical pattern I see, okay? So just more tips and tools that you guys can look at. 2 areas that I see people get really stuck with is rumination and worry. So the ruminators are just stuck on pre-tinnitus, post-tinnitus, and they just can't get past this, and this is their new life, and are you really telling me I have to live with this? And the worriers are convinced it's going to get worse, or what's going to happen next. Now that it's done this, I don't know what is it going to do, in 10 years. And the interesting thing is sometimes these are patients, not always, but sometimes they're patients where on any given day they might not even hear their tinnitus. But they did at one time, and it threw them into this emotional spin. And they're stuck there. Even on a day when I'll say, well, rank your tinnitus today on loudness 0 to 100. I'm not sure if today I can even hear it. But that worry of, well, it's going to come back, or what's going to happen next. So these 2 areas I find patients will sometimes get stuck in, okay? I like to use mantras all the time, because your job is not to be a cheerleader, but your job is to help them manage their own tinnitus. And so a mantra is a way for they can self-talk to themselves throughout the day in the beginning phases when they are very distraught. And a mantra is very simple, and it can be as simple as, this is okay. The more you say, this is okay, the more it becomes. And I'm going to challenge you to ask a tinnitus patient that you're working with who is greatly bothered, what is the first thing you thought about this morning when you woke up? And most people will say what I was going to eat, what I was going to drive, what I had to do. And someone who's stuck in that really bothered time will say, well, my sound. And if my sound is loud, then I know my day is going to be bad. Or, if my sound has this ring, it has the double ring, and if this ring's there but this one's not, then I know it's going to be a good day. That's when you start with a mantra. Like, what's the first thing they can say to counter that so that their day is not hooked to what their tinnitus is doing? And mantras are really fun to create. I've got lots of handouts on mindfulness. I love to use a stock market graph because I tell patients this is your journey. I don't know of any tinnitus patient who goes from A to B on a straight line thanks to technology, counseling, or tools. It's good moments, bad moments, good moments, bad moments, and the hope is when you get from A to B that those dips and those leaps are just tighter and tighter as you go. And in the beginning, it's really big, and that's okay. But we're going to, try to get you in another state. I like to use, and maybe other clinicians use a different timeline, 1 year from when a patient comes into the clinic who falls in that greatly bothered category. 1 year, that's the timeline. Let's see where you're at in a year. Because that's sometimes how long it takes to get product on board and get counseling in place and start making some of these changes. And it happens gradually. There's a 6-month mark and an 8-month mark, but that 12-month mark is really when I see people just fade away from counseling or they're just in a better place in their life, okay? Pop psychology, I don't know. I picked up this magazine. It says, stop worrying, start living. What can you do? Well, maybe that's an exercise. Maybe if they are going to search on the internet, let's stop searching about tinnitus, but let's start searching about what you can do for rumination, okay? Basic relaxation tools, I think they need to be in your toolbox. Muscle relaxation imagery training. This gentleman who was using the neuromonics for sleep, we had to give him the Oasis because of lots of reasons, and it has a built-in, coach who talks you through muscle relaxation so that he could just pop it on, at 8 o'clock in the morning when he was trying to sleep. I don't know much about neurofeedback, but the gentleman yesterday was talking about it, and it can be a good tool. But there is one really good tool by Gerhard Anderson. It's in the book Tinnitus Treatment Clinical Protocols. It's an applied relaxation technique, and it takes 4 weeks to master it, which is perfect. So you give your patient on week 1 the week assignment, they come back, you do week 2, you do week 3, and you do week 4. And then maybe it's what do you need to do for better relaxation? Things that you can try for someone who's extremely depressed. And then when it comes to the partners, I mentioned this a little bit yesterday, at some point you need to guide the patient to talk to you. You're the resource. Family members want you better, they can't help you, and at some point they burn out. And they just feel like, I can't help you, and all you do is complain about your tinnitus. And so that's what we're there for, the venting. So I had one gentleman who did telephone counseling once a week for 30 minutes a week for a year. And that was it. And all he wanted was someone on the other end so he could complain and talk about what he hated and then remind himself on what he needed to do to not hate it. And it was like a shot of therapy. And it worked great for him. And it helped the spouse. The spouse would say things to me like, I don't know what you're doing, but he's just so much easier to be around. Well, it's because he's not using you as the therapist anymore. So that was just really fun and great. So do you remember that physician Terry Nagler? Well, he has a wife, and she wrote an article, Tinnitus Spouse Survival, and I hand that out, and I'll have that on my website. So the spouses need to know what to do and how to help, and this is a great resource. So this is just advice that I got from a patient who'd been in counseling for a year, and he kind of weaned out. And his comments are this to other patients. I said, what would you say to another patient who is where you were a year ago? And he said, work with a tinnitus professional because they understand what's going on, but be open to working with others as needed. Stop talking about your suffering with your friends and family members. They love you, they want to help, but there's nothing they can do. Keep those discussions with your tinnitus professional. Have faith that things will get better. And no matter what the characteristics of your tinnitus, whether you do hearing aids or a combo unit or neuromonics or sound care or all the cool things we heard about today, also work on your thoughts and really address them and see where they're at and see where you can make some changes. So lastly, I want you to know that in the stuttering world, there are a few DVDs that really talk about counseling. And I think they're kind of neat and helpful if you're going into this field. And this gentleman, David Luderman, I'm not sure how to pronounce his last name, he says from the get-go, you're not a cheerleader. You just don't, it's going to be okay, yeah, because you don't know it's going to be okay. But you guide them, and your best compliment as a tinnitus professional providing counseling is when a patient just stops treatment or they fade off and you've taught them tools and out the door they go, okay? And then lastly, I stumbled on this DVD also. This is by Ross McCowan, and he just interviews himself and talks about the 4 keys to successful tinnitus management. It's everything we've talked about in this conference, but in a layman's terms. And so it might be something you just give to a patient and have them watch and then bring back, okay? So that's it.